Hello, now I'm going to do part 2 of the female reproductive system. So part 1, reviewed anatomy, physiology, ended with endometriosis, talked about a lot of STDs. So now we will continue on. So let's do it. All right, beautiful. Artwork of a uterus, I like that. All right, so dysfunctional uterine bleeding. Indeed, that's why you take a nice history. You see when was your last period, how regular are you, what's your pain like, how much blood. You got all these clues. But look at this example. You got bleeding, throughout in the middle, the menstrual cycle, not too good. And usually looking at hormone issues. Well, it could be hormone or it could be a structural problem that causes this. And pretty much, diagnosis of exclusion. You take a look at all the issues that it is not, and it comes down to what could this be? And I said everyone's variable, but if they can exclude some causes, and if they can rule it out, then they brings them closer to what, if there's anything that could possibly be done. Yeah, and of course, once you get near menopause, the bleeding and your cycle gets all out of whack. It's usually very regular in the middle, and then in the beginning and the end of when your periods begin and end. Is it more out of control? And people that have unpredictable periods, birth control, really takes control of your hormones and can keep it very regular like that. Now, obesity. This obviously men and women are obese. It's certainly, no sex can claim that. But particularly related to hormones, obesity is an issue that often throws off cycles, and it causes infertility as being obese. Being extremely thin also is going to affect fertility too. You're not going to have cycles. Evolutionarily, you need a certain amount of fat in order to be able to carry a child and to reproduce. But you'll see that adipose tissue, aromatase, and there's drugs out there, aromatase inhibitors. Some of these are involved in looking at cancer too, because you'll see cancers respond to hormones and estrogen, and so there's some ways we can get cancer drugs by aromatase issues. So you're gonna have elevated excessive estrogen is gonna screw up your cycles, and also put you at risk for some of these cancers, because they respond and they grow faster because they have estrogen receptors, and it makes them grow quicker. All right, polycystic ovarian disease. We talked about it in polycystic kidney disease. Now this is on the ovaries. And so you'll see ovaries, usually, so the follicle just keeps growing and makes these big cysts. Remember the follicle, the cells made hormones, small amounts of androgens, male hormones. But when you have all these cysts, you have higher levels of these male hormones. And so you may see hormonal imbalances like this caused by having these cysts on your ovaries. 5% of women, so pretty common. And you can look at the symptoms here. You see mood changes, fatigue, trouble getting fertile, cysts, lower sex drive, high testosterone levels, insulin resistance, so they'll look, if you some of these issues, they'll looking at diets, and always birth controls, giving you exogenous hormones can help with a lot of these things. So menopause, you're pausing your menstruation, not pausing it, you're stopping it, right? Not pressing the pause button, the stop button. It's at about age 50, and so you've got 40 years of times 12 months in a year of menstrual cycles, and take a look. You can see you're at the end. It's very irregular too. So a lot of issues when you see women late 40s, 50s having hormonal fluxes and having menstrual cycles that are all strange and weird. And then you're going to have obviously hormone decreasing, and that's Well, you're going to decrease your estrogen, progesterones, and follicle stimulating hormone like peaks, but there's no follicles to stimulate, and so again, there's a lot of hormone stuff going on there, and there's often a case where you need some endocrinologist to really to make the life as easy as possible for you at that point. So some of these symptoms, again, age. I mean, you obviously know if you're 48, 49, and you're getting hot flashes and you're feeling mood differs and your period, you know what's going on here. So yeah, all these things, and vaginal itching and intercourse is estrogens really keep things help with that. And so with lack of that, there's estrogen creams you can even put on and such to help get rid of that dryness. And hormone replacement therapy. And you guys, maybe you've heard there's some controversies here because, again, you could say, well, we'll just replace the hormones and that will, the dryness will go away, other issues will go away. But there's cancers that are activated by estrogens. And so by giving extra estrogen, you could be speeding up some tumor growths. Yeah, and risks of stroke. Definitely, there's a lot of estrogens. There's receptors on many of your organs, so it's not just estrogen's going to work on your ovaries or something like that. It's complex. Yeah, another thing that happens when you have drops of estrogens, you're going to have more osteoporosis too, and so that becomes a risk factor too. So that's a plus for taking estrogens. But yeah, your book mentions this, that there's differences, cultural differences in menopause. And in some cultures, you're depressed because, I'm useless as a woman because I can't have babies. In other cultures, it's a relief, like, oh my God, I'm done with this, I can enjoy life. So just to let you know that people come at it from various ways. And so how they react to it physically and mentally is quite different. So keep an open mind for people that react differently to menopause. All right, a couple of things. I narrowed this down to one slide looking at this lichen sclerosus. Remember, a lichen kind of grows on a tree. It's kind of flat like that. And so you see kind of some lighter areas like that grow on there. And often postmenopausal changes in hormones can do that. But leukoplakia means white plaque that grows. Skin diseases, your labia, everything, that's just skin. It's just additional skin. So anything that happens out here can happen on that skin as well. And so this lichen sclerosus, there's another form that you want to get checked out, like what's going on here, but often it's like, it's a skin issue. We can fix that. All right, finally to the neoplastic diseases. And of course, famously, you guys know ovarian cancer, right? Cervical cancer. We'll talk about breast cancer in the next lecture. But yes, so we'll talk about these. So first of all, a neoplasm doesn't have to be cancerous, right? And that's what a leiomyoma sounds right. That's going to be a smooth muscle fibroid that you find that'll grow in the uterus. And you can have other benign tumors. But then carcinomas, cancers, the ones you hear about are, ovarian, cervical, and uterine cancer. And we could take a look. You guys can take a look at these, see what jumps out to you. Yeah, I see the ovarian having the lowest 5-year survival. But it's first detected later. Your ovaries are quite hidden, and you can have ovarian tumors that go really big and you don't even know it because it's so hidden. Yeah, often ones, in other places in your uterus and stuff, you'll notice changes and differences. But you have a lot of room to grow in there for a tumor. So if it's detected very late, of course, your survival is going to be less, right? Cervical, it's hidden as well, but if you have it regularly checked, they will find that. They won't check for an ovarian tumor unless there's some kind of symptom, some pain, or unless they have some reason to look. All right, so this leiomyoma is going to be, they call them fibroids. And fibroids form in the muscle of the uterus, and estrogen makes them grow. And so they will grow once after puberty. These will grow in the uterus, and sometimes they cause problems, and sometimes they don't. See, most you just got fibroids, and they're growing in the muscle. It's just kind of this thing that grows. But it could impact the inside of the uterus, and so if you're getting pregnant, you have fibroids, that could be a problem. Yeah, and it's growing towards the inside. It has been implicated in causing more menstrual bleeding too. So fibroids, they can be removed. So they go in and they'll just kind of take out the fibroid around the muscle, and then a term I hope you all know is hysterectomy. Take out the whole uterus, right? So you can just remove the whole uterus. Yeah, you can live without a uterus. There's a lot of women walking around without a uterus, just fine. Indeed, if you take out, you can leave the ovaries and still have hormone production, but without the uterus, you don't menstruate, obviously. You obviously can't get pregnant, but it takes care of, if you have uterine cancer, take it out. You got too many fibroids, take it out. I say this lightly, but it depends, of course, on your individual self. And if you really dying to have children, then okay, you don't just take it out. Then you look at some other options. But I'm just saying you can if you're just talking about your life. Yeah. All right. Again, estrogen makes them grow, so you can fool around with the hormones to maybe do that. Ablation, you can also take some of the arteries that are feeding it, and you can clog them off to starve it so it doesn't grow. But fibroids are just neoplasms that are not cancerous, but they can grow and cause issues. Yeah, so benign ovarian neoplasm is just going to be a tumor on the ovary. It can be solid or it can be liquid, and it just grows, but it's not going to spread. Yeah, and it gets big enough, then you can feel it when you do that bimanual examination. Mm-hmm. Or they can do some imaging and like, the hell's on your ovary? They can get really big too. There we go. There's a 50-pounder, right? So yeah, as I say, if you have a lot of room in your abdomen, these things can just grow. And there's even bigger ones than 50-pounders. Yeah, you can Google it. Yeah. And where do these things grow? I mean, on the ovary itself, go a little more detail because this gets a little bit into the weeds here, but it can grow from the surface cells or from the germ cells, the egg cells, or from the stroma, or the connective tissue around it. Surface tumors are usually just going to just come off, usually fluid cysts. You can see them here that just kind of bubble off of it. You can imagine one of those follicles, once it's ejected the egg, that fluid can build in it, and if it just builds too much, it's going to make the cysts. Ones from the germ cells, they also grow, also be cysts, but the interesting thing I want to mention here is a teratoma. If you should look that up because it's wild stuff right there. This comes from a germ cell tumor, and these, which means like the eggs, so they can make like any kind of tissue, right? So you'll see these teratomas inside that'll have hair and teeth and other bone and other body parts. I just found a couple on Google Images. Just imagine a tumor you open up and there's hair inside of it and teeth. So these things, obviously, the genes are turned on to grow all these weird stuff in a tumor, right? So wild. And then if it's a tumor that began just in the interstitial tissue, the connective tissue around the eggs in an ovary and not on the surface, yeah, fibrothecoma. And the theca is the layers that go around the follicle of the egg, right? And so sometimes if there's a tumor there, they'll make tons of hormones because here's this hormone producing tissue, and then you just divide it a million times, all of them are making hormones. So that is sometimes an issue. Yeah, right. So these things, these thecoma, remember theca is the layer around the follicle layers. The layers will go around, especially the developing follicle gets big. The theca layers get really big. And so causing these hormones can cause issues with hormones like menstrual cycles changes or androgenic effects, meaning male effects like voice and everything like that. Indeed. So these ovarian tumors, Some of it's, you can see, it's a judgment call, and they can remove an ovary, and you can still be fertile with just one ovary, although less fertile. So you can see that you take a woman's wishes into account. Just depends. And if they're done having kids, it's like, take them out. I don't need those. And again, hormones, you can have replacement therapy for that. All right. So you can see ovarian tumors, you got the, as I just mentioned, surface, germ cell, or the stroma, and then some other ones. All right. So endometrial carcinoma, so cancer in there. I see most common of these cancers, the female tract in the United States. Yeah, normally postmenopausal, definitely, yep. And especially associated like lots of estrogen stimulation. These cells have receptors for estrogen. And how do they know they have this endometrial cancer of the glands of the endometrium? Usually you'll have some abnormal bleeding, and you go in and then they can do a biopsy of the endometrium, and they'll see, oh, these gland cells have mutated enough so that they've become cancerous. And if they can do a hysterectomy, sometimes they can just remove the problem completely. Yeah, so showing some endometrial cancer. So like all the cancers, right? It's a matter of making enough mutations so that it's not only grows out of control, but could have the ability to metastasize or spread. Yeah, so simple hydroplasia with cells that are atypical. You start having weird looking cells, and to finally adenocarcinoma, where those cells from the glands are truly cancerous and have the ability to spread. All right, ovarian cancer. So unlike these benign cysts, here's going to be malignant neoplasms, and it grows on the ovary and spreads. And so again, from the surface germ cells or from the connective tissue. Most of the surface ones they worry about. So what are some risk factors? If you have a familial, if you have family members that have also had ovarian cancer, then you want to make sure and get that checked. Obesity, this means not having kids, or you're getting a lot of estrogen. So obesity, also that aromatase, remember that? You're going to have a lot more estrogen, and or you're taking estrogen that is going to really fuel the fire of these kind of cancers. Yeah, and being older. So the problem with ovarian cancer is that we usually don't catch it early because it can grow a long time in your ovary without you noticing it. So that's at like stage 3 or 4, by the time we catch it. So yeah, if they do happen to come upon it, it's easy to cure, but it's hidden in your abdominal cavity, and it usually gets really far. Yep, and depending on what stage it is, they can go in and remove the ovary, of course, but maybe remove lymph nodes in your pelvis and parts of your uterus, depending on where it's gone. Cervical cancer. All right, this one was a big killer, higher than it was now, but with these pap smears, these tests, we've really brought that cervical cancer way down the list. So it's a good success story with these screenings. HPV, this virus we know, goes in and changes the cells and really fuels the fire there with the cancer. Yeah. Right, I was looking at HPV also. Can cause oral issues as well, yes. So where this really works is that in the cervix, you have this transition between the squamous on the outside, stratified squamous, non-keratinized. And then when you go inside the cervix, it becomes columnar, as the endometrial lining is. Yep. Yeah, so these genes go in there and they cause these cells to become immortal, to live forever, to keep dividing, and you can stage it if you're good at this. Look at a biopsy. See, this is pretty normal. It is normal. Noticing this stratified squamous non-keratinized looks like the vagina or cervix has this look to it, these stratified look. But then, yeah, looking more and more weird as the cells are more and more cancerous. And then to do the cytology of it, here's a nice, you guys remember doing cheek swabs and looking at a microscope. That looks like epithelial cells, right? You saw those in in the urine when you looked at that. And then you see cells, if you're good, you can say, oh, wait a minute, these are, they talk about they grade what the cells look like. And this one is a high grade, meaning it's really unusual. And it's cause for worry compared to ones that are just about normal. Now, again, the HPV, I've already mentioned it, but there are a couple high-risk ones, strains of it that are really cause cervical cancer. Yep. And then there's those that cause warts and not the cancer. Yeah. But we do this pap smear, and we're able to gather some cells. Pathologist looks at it. You get a call, or it's in your medical records, it's yay or nay. You know, if there is a problem, the cells look unusual to the pathologist, they'll have you come back in, and then they'll go and do a little biopsy and take a look at it. If cells look fine, then see you next year. Yeah, definitely. So, yeah, they'll go in there. Yeah, they shows if they're going in there, they'll put they got a special way to look in there with this scope and be able to take a look and take some pictures, look at your cervix, and then take a biopsy of it too. Yeah. And this conization, this is when they come in and they take a cone of tissue out, and they can do that, and it's okay. It'll heal over, and you could still give birth, everything like that. But it would be a good idea if they can remove all those cells to prevent them from spreading. And if it's really invasive, then they'll look at radiation and other chemo, things like that. All right, the spontaneous abortion is just miscarriages. And as I said, very, very common, you know. And if there are some real issues, and it could be either, you know, genetic issues that the embryo was never going to make it anyway. There was issues before that, or with the mother, there can be issues where her hormones are delicate, or her anatomy is such that heartbreaking if your anatomy is not quite right and you keep trying to have kids, and depending how long, you know, before this miscarriage happens, of course, it's terrible. Yeah. Okay, ectopic means not where it belongs. It's going to be not in the uterus. So this can happen. Imagine here that you have some scarring on your oviduct, your fallopian tube, and then so it narrows the lumen. And so the egg was released. The egg made it down the tube. The sperm came up. They swam past that, no problem. They're tiny. But then the egg is fertilized, starts growing, and then it's going to stop. It can't get through that constriction. What happens, it actually implants on that tube and starts growing. Yeah, you got an embryo, then a fetus trying to grow in your fallopian tube. Not going to happen. It can start that way, but it's not going to grow like a uterus, and it's just going to burst and kill you, maybe, right? Also, believe it or not, you can have an egg that's released from the ovary, and it doesn't make it down the tube. It like floats around in your abdominal cavity, and the sperm come up. Sperm are like, hey, here we are. And they're going to fertilize it, and you can have it on a piece of intestine. You can have an ectopic pregnancy out there. It's going to start growing, but it can't go very far, right? The uterus is special. It grows big. It makes this great connection. You know, it's the way to go. But we can't, nothing else is a site where it's compatible with life. But you can have an ectopic pregnancy on your tube, on the outside of your uterus, on the intestines. And the danger here is, of course, this growing embryo is going to it's going to burst your tube, and then it's emergency because the blood's you're going to bleed out if you go in there. So tremendous pain. It's an ectopic pregnancy. The thing is, you didn't even know you were pregnant many times, and so it's just kind of a mystery. You don't know what's causing this sudden pain, but definitely want to get that looked out. Yeah, look at this. So various places here showing where you can have ectopic pregnancy. Yeah, so the uterus is where you want it, right? But in the muscle here, in the cervix region, way too far, in the tube, yeah, on the ovary or in the abdomen. So all these places a fertilized egg can start growing. It's an ectopic pregnancy. And so how do they know you have an ectopic pregnancy when they come in? Well, you're going to see HCG because the developing embryo and fetuses gives this off. It's going to be detected. They look at the uterus, it's like, nothing there, right? But you're pregnant, so it's somewhere else. Yeah, definitely. And then they can do an ultrasound, or they can find it elsewhere, and it's not compatible life. So methotrexate will take care of the embryo. It will stop the embryo from growing anymore, and you'll just abort it, and because that was never gonna happen. And so what are some risk factors? Again, any scarring of the fallopian tube, so pelvic inflammatory disease, endometriosis, anything, so that tube needs to be nice and delicate with this opening. There has to be cilia that move it along. Some diseases of the cilia will make you infertile because it doesn't move the egg along. So it needs to be patent and healthy, so the egg can move all the way down and make it to the uterus. Because the most commonplace ectopic pregnancy is a tubal. It'll be in the tube. It didn't make it all the way down. Yep. All right. Septic abortion is when you have an abortion, and usually it's not done by a professional, and so non-sterile, and it's a big infection in your uterus, and can spread and cause death. So back in the day, or if you have an abortion, you know, some back room or someone that's not in a hospital, you know, it's not going to be, the instruments aren't going to be clean, and it's life-threatening, potentially life-threatening, and you need antibiotics. All right, now this is a disease here. We're looking at involved with pregnancy, but you can have a placenta. Look at this forming in just the wrong place. You know, you want it on the walls, but if it forms down in that cervical region, that's just not going to work. So, yeah, it's the placenta has to form in the endometrium in the right place. If not, it's not going to happen. Previa, if it's too low down there, yeah. Accreta, if it's in the muscle, not good. When you hear, yeah, so here's a previa. You can see the damn thing started down here, you know, it's supposed to be not on the side, so it's going to be a big issue. But placental abruption, that's when the placenta separates from the wall of the uterus, and bleeding, blood will form in there, and the baby might need to come right then, you know, if they can't stop that, you know, hold it off if it's, you know, not time for term. But mom can go into hemorrhagic shock. The fetus will be separated from the blood supply. You'll have problems. Yeah. So if you're a young pregnancy, or very old pregnancy, or high blood pressure, those are risk factors to the placenta coming off. All right, you've all heard of these complications of pregnancy, I think, eclampsia, preeclampsia. But there's a lot of mystery what causes this, what's going on exactly. But we know it's a real thing. Preeclampsia is when you're going to have high blood pressure. You also see protein in the urine, and edema. You just see these things that happen in a pregnancy. If you notice, oh, your blood pressure is like way too high. I mean, it can be increased because you're pregnant, but then you're like, oh man, you could be preeclamptic. And see, 5% of pregnancies, this happens, and it can go into eclampsia. And that's you can see you can go into a coma, et cetera, but causing 15% of prematures and 20% of deaths. So this is they take this seriously if you have preeclampsia. And then eclampsia, the involvement becomes more severe. You can see seizures and stuff, and so that's a serious condition. Yeah. So, what are the goals? I mean, you know, try to, when you give birth, it gets better. That's a strange thing. It's this pregnancy-related high blood pressure and other issues. And if they can get the mom stable enough, just get her through, you know, preeclampsia. If you can get her through the delivery, you know, she'll be okay, you know. Yeah, so we're not exactly sure what's going on there. Interesting. You know, first pregnancy, more risky, or you've got twins or triplets, more risky. All right, and lastly, we'll talk about organ failure. Well, first of all, you want the reproductive system to fail if you're not ready to have a baby yet, right? So you're like, come on, fail, right? So you can have temporary infertility with birth control. So we do that, and you guys are familiar with those. Or you can have permanently stop the uterus. A hysterectomy works, definitely. You can move the ovaries, that works. Or you can have a tubal ligation, it's called. You can just clamp or cut the tubes. And again, remember, any kind of stenosis in the tubes or scarring will prevent, oh, then you can have ectopic. You don't want that for sure. So you want to stop, don't let any eggs come down there. But you can, of course, again, remove everything. And we live fine without testes or without ovaries or without a uterus. And birth control, I'm not going to get into all this. You guys probably familiar there, but so cool. The male birth control pill has issues. They're kind of working on it, but there's all kinds of interesting things. It's more difficult because we make a lot of sperm. Women, you got to prevent that ovulation, that one instance, not, daily production of sperm. So it's a whole, they're working. It's so cool to think about. Definitely. Yeah, but vasectomy, yes, you make sperm, but I stop them from being transported anywhere. Definitely. And things like condoms or coitus interruptus, pulling out idea. It's better than nothing, but it's not much. You can see that tubal ligation comes here where you do ovulate, but they don't make it down the duct, of course. And then, yeah, morning after pill down here. That's another drug that will cause you to menstruate, and we'll take care of that. Anyway. Yeah, let's take. Oh, then I put this on here too. Looking at what are the success rates? Yeah, interesting. Yeah, the rhythm method is where you time your ovulation and you don't have sex around ovulation time. You can see this is out of a pregnancies per year per 100. Yeah, so yeah, what do you think? 20%? Is that that's a pretty high number, isn't it? As we compare to the pill, like some 3%. Tubal ligation, 0.4%. So there's just a tiny fraction where it was not done correctly, or somehow, I don't know how that would work. If you remove the piece of tube, it should be fine. Yeah. Vasectomy. Yeah. Very, very good. All right. Some bad ones. I mean, the condom, it's all about, you can use it, but is it going to break? Is it going to be an issue with it, really? It's so that's where the failure rate comes in. And the withdrawal, yeah, 4 to 18. I'm surprised it's that high. Yeah, anyway. All right. So what about you're infertile but undesirable? So this is you're not doing that. And so, couples will try it. Say after a year of unprotected sex and there's been no pregnancies, they could take a look at what it is. And so, a third of the time they look to the male, look at sperm numbers and sperm motility and anatomy, see if it's that. If not, they take a look. Are you ovulating? Do you have ovaries? All kinds of things like that. Yeah, so you can see there's many places hormone-wise and anatomical-wise, and now you have two individuals involved where things could go wrong if you're trying to have a baby. So infertility, look at age here. Looking at we're looking at women here. You can see fertility rate. Look at it drop. Oh my God! If you're in your late 40s, your fertility rate, it really, really drops. And why would you have spontaneous abortions? Also, the older your eggs, the more possibility for genetic and chromosomal issues, because they've been sitting there for decades and kind of like in storage. So the rates for some issues go up when you have children later, and your ability to get pregnant, of course, goes way down too. And actually, today's society, women are having kids later and later. There's careers, other things, sociological impacts that are causing us to have children later. And there are issues, of course. If you wait too long, it gets more difficult to get pregnant. Yeah. All right, and finally, our last slide here. So if you're looking at infertility, of course, you need to look at both partners. And again, there's whole clinics and medicine devoted to helping couples that want to get pregnant do it. But you can see from endocrines to psychological to anatomical issues that could be in your way. And definitely, again, there's ways around this. I don't have time to lecture on that, but in vitro fertilization, you can have a surrogate. There's all kinds of issues in adoption that if you ways to have kids if all these things fail. All right, you guys. Covered a lot of ground here. The issues we're looking at the male versus the female. You can see really different functions. All the ovaries and testes, they develop from the same tissue and they have similarities. The hormones surrounding it, and then the female has all this apparatus to maintain a fetus, you know, the uterus and all this. And our next lesson should be on the breast. And of course, that's females have that in order to nourish this fetus. So males make the sperm, they make a lot of sperm, and they need a penis to get the sperm to the female. And the female then needs to have a place for the fertilization to occur. And then, 9 months of nourishing, taking care of this, and then years and years of breastfeeding, and then years and years of paying for college tuition, things like that. Anyway, all right, I think we are done.